Do you know that a single mistake in positioning a patient during surgery can lead to nerve damage, tissue injuries, joint dislocations, and even bed sores? Yes, just one mistake. Surprised? In this video, we are diving into science and art of surgical positioning, a topic that is absolutely critical for every medical student, young doctor, and surgical resident. Because as a surgeon, mastering operative table position is not just a skill, it's a responsibility. Hi, I'm Dr. Hazi Arifuddin, surgeon, educator, and your guide to mastering surgical skills. Today, we are going to understand surgical positioning in a way that helps you in exams, in operation theaters, and most importantly, in protecting your patients. So stay with me till the end because we will cover a real life risk, common mistakes, and practical tips that senior surgeons actually follow. Now, let's start with the basics. Patient positioning is a vital for a safe and effective surgical procedure. It depends on the type of surgery, the duration of procedure, the type of anesthesia, access to the airway, access to the intravenous line, and overall condition of the patient. The goals of proper patient positioning are very clear. We must maintain the patient's airway and the circulation throughout the surgery. We must prevent nerve damage. We must allow proper access to the surgical field as well as to the anesthetist. We must provide comfort, safety, and dignity to the patient. And we must prevent soft tissue injury, musculoskeletal injury, and pressure sores. Remember this, pressure could never be concentrated at one single point. That is how pressure injuries develop. A sedated or anesthetized patient cannot tell you that something is hurting. They cannot complain of numbness, tingling, excessive pressure, or abnormal stretching. And when anesthesia and muscle relaxant suppresses the pain receptor muscle tone, then body's natural defense mechanism are completely lost. Now combine that with a risk factor like old age, diabetes, anemia, malnutrition, obesity, vascular disease, or long surgery duration, and the risk of injury increases dramatically. That is why proper surgical positioning is not optional. The objectives are simple: facilitate safe anesthesia and surgery, reduce the physiological stress, optimize surgical exposure and ergonomics, and always maintain the patient dignity. Good positioning is not just about comfort, it's about physiological stability and prevention of complications. Now let's go through the positions one by one, exactly how you should understand them. Let's start with the most common position, the supine or dorsal decubitus position. In this position, the patient lies flat on the back. This is the most frequently used position in surgery. The arms may be placed by the side or extended on arms boards to allow intravenous access and arterial access. This position is commonly used for abdominal surgeries like laparotomy, appendectomy, and hernia repair, as well as cardiac surgery and head neck procedures. The advantage is that it provides natural body alignment and is stable for anesthesia, but the risk is increased pressure over the occiput, scapula, elbow, sacrum, coccyx, and heels. So always remember, pad all the pressure points and never abduct the arm beyond the 90-degree because that can cause brachial plexus injury. Now let's move to the Trendelenburg position. Here the patient lies supine but the head is lowered below the level of feet. This position enhances the venous return and improves the exposure of lower abdomen and pelvis. It is commonly used in pelvic and lower abdominal surgeries and it is also useful during shock resuscitation. But there is a risk of increased intracranial pressure, increased intraocular pressure, and respiratory compromise. So, the key tip is always tilt the patient gradually. Sudden tilting can cause hypotension. Next is the reverse Trendelenburg position. In this position, the patient lies supine with the head elevated above the feet. This is useful in upper abdominal surgeries, head and neck procedure, and laparoscopic surgeries. But remember, this position increases the risk of deep vein thrombosis, so preventive measures are very important. Now, let's talk about very exam important position, the rose position, also known as caucus position or the barking dog position. This position is mainly used in thyroid surgery. The patient is placed in a reverse Trendelenburg and the head end is raised by 15 degree and the sandbag or pillow is placed under the shoulder to extend the neck. This increases the space between the clavicle and the jaw, making the thyroid more prominent. But there is an important risk, air embolism. To prevent this, veins must always be ligated before division, and any air in the internal jugular vein should be aspirated immediately. Now let's move to the lithotomy position. In the lithotomy position, the patient lies supine with the hips and knees flexed and the legs are placed on the stand. In the standard lithotomy position, the hips are flexed to 90 degrees. A modification of this is Lloyd Davis position, where the hips are only slightly flexed around 15 degree with a 30-degree head down tilt. This position is commonly used in gynecological, urological, and perineal surgeries. It provides excellent access to perineum, but it carries significant risk. These include fractures, hip dislocations, nerve injuries, muscle injuries, pressure sores, reduced lung capacity, and especially common peroneal nerve injury. Both legs must always be moved together. The legs should not be excessively abducted or externally rotated. Fingers should never hang beyond the edge of the table, as accidental crushing or even amputation can occur. Sequential compression device should be used to prevent the venous stasis and deep vein thrombosis. Now let's talk about the relieved supine position. This is simply the supine position with slight elevation of the knees. This is used in long duration abdominal surgeries to improve the comfort and venous return. Next is the prone position. In the prone position, the patient lies flat on the abdomen. This is commonly used for spinal surgeries and posterior rectal procedures. The advantage is excellent exposure of posterior structures, but the risk include brachial plexus injury, chest compression, facial pressure injuries, or even vision loss. Chest rolls and axillary rolls are essential. The abdomen must be free to move. The eyes, breast, and genitalia must be carefully protected, and the endotracheal tube must always be checked. A modification of the prone position is jackknife position, also known as Raski position. Here, the hips are elevated higher than the head and legs. This position is commonly used for anorectal procedures like hemorrhectomy and perineural surgery. But remember, this position places extreme pressure on knees, so extra padding is mandatory. Moving to the next position, that is the lateral position. Left or right lateral position is useful when prone positioning is not suitable. It is used in thoracic surgeries, drainage of perianal abscess, and perineural surgeries. A modified lateral position called kidney position is used in urological and retroperitoneal surgeries. This is achieved by breaking the table to increase the distance between the postal margin and iliac crest. In this position, the lower leg is slightly flexed. A pillow is placed between the legs and the upper leg is flexed more. Cervical alignment of the head is extremely important. Now, the complications include respiratory compromise, brachial plexus injury, ulnar nerve injury, and accidental endobronchial intubation. Now, coming to the Sims position. Sims position is a variation of left lateral position. It is commonly used for rectal examination, sigmoidoscopy, and enemas, usually in awake patient. Now, let's discuss the Fowler's position. In Fowler's position, the patient is semi-seated with the back inclined between 30 and 90 degrees. The position is used in cranial surgeries, facial procedures, breast surgeries, pressure injuries, and deep vein thrombosis. The head should always be kept in a neutral position, the arms secured, the buttocks padded, and the knees slightly flexed. There is also other special position like the lithotomy Trendelenburg hybrid, knee chest position, and supine frog leg position, which are used based on surgical requirements. Finally, securing the patient is critical. Safety belts should be placed 5 cm above the knee, never over the abdomen. Shoulder support are used in Trendelenburg position. Side supports prevent lateral displacement. Foot supports are required if reverse Trendelenburg position is given. Vacuum activated positioning system can also be used. Before starting any surgery, always plan positioning preoperatively, considering the patient's age, body habitus, and joint mobility. Use appropriate padding and supports, and during long surgeries, keep checking the pressure related complications. Let me end with this. Overextending the arm can cause brachial plexus injury. Forgetting to pad bony prominences causes pressure sores. Ignoring patient specific factors lead to avoidable disasters. Small adjustments save nerves. Small adjustments save limbs. And small adjustments save lives. Mastering surgical positioning is not optional. It's a cornerstone of safe surgery. Subscribe for more exam focused and clinically practical surgical content. Check out my list on mastering surgical techniques. Let's learn, let's grow, and let's save life together.